Bismillahirrahmanirrahim. We are discussing about speech. In the last lecture, I told you about the speech mechanism. What is mechanism of verbal speech or spoken speech? We discussed about phonation, articulation, and resonance. Today, first about the control of the speech mechanism. In the dominant hemisphere, which is of course most of us are right-handed, so left hemisphere, so left cerebral hemisphere is the dominant hemisphere. In this dominant hemisphere, there are speech centers or speech areas which control the speech mechanism. Keep in mind that even in the persons who are left-handed, left hemisphere is the dominant hemisphere. So even in the left-handed persons, the left hemisphere is the dominant hemisphere. So these areas in the concerned speech in the dominant hemisphere, these include motor speech area, sensory speech area, and then the other areas we discussed. So first speech area, a speech center is motor speech area. Motor speech area. Also called Broca's area. Broca's area. Also called the area of word formation. Area for the word formation. Broca's area, motor speech area, is located in the inferior frontal gyrus. Inferior frontal gyrus, just anterior to face representation in the primary motor area. Just anterior to face representation in the primary motor area. This area receives impulses from vernix area along the arcuate fasciculus. So Broca's area, motor speech area, it receives impulses from the sensory speech area, the vernix area, along the arcuate fasciculus. In Broca's area, there is formation of detailed motor pattern for the contraction of muscles of phonation and articulation is formed. So in this area, formation of detailed motor pattern for the contraction of muscles of phonation and articulation. Right? And from this area, the Broca's area, motor speech area, impulses go to the motor cortex to initiate contraction of the muscles of phonation and articulation. So from this area, impulsive signals go to the motor cortex to initiate contraction of muscles of phonation and articulation. Broca's area, motor speech area, is Brodmann's area 44. It's Brodmann's area 44 is the motor speech area of Broca's speech area. Next speech area is vernix area. Vernix area located in the posterior part of superior temporal gyrus. So located in the posterior part of superior temporal gyrus. It is Brodmann's area 22. So area 22 is the vernix area. It's Brodmann's area 22. It is also called the sensory speech area or general interpretative area. Sensory speech area or general interpretative area. This area is concerned with higher intellectual activity. So Wernicke's area, also called sensory speech area, is concerned with higher intellectual function. In this area, spoken and words are received. Similarly, what is being seen is received. So all the visual and auditory signals, of course, for these go to the primary motor, primary auditory, and primary visual areas. So from these, the impulses go to the Wernicke's area. So Wernicke's area receives all the information regarding the vision and the hearing. In this area, thoughts are formed. Thoughts are formed. What to be expressed is decided. Words are chosen to express the thought, express the ideas. Words are arranged into sentences. Words are arranged into sentences. And then impulses from the Wernicke's area go along arcuate fasciculus to the Broca's area. So Wernicke's area is concerned with the higher intellectual function. Here all the visual auditory informations are understood, thoughts are formulated, words are chosen to express the thoughts, words are arranged into sentences, and then signals go to the Broca's area along the arcuate fasciculus of this area. So this was about the Wernicke's area or sensory speech area. Our next area is area for the naming of object. Area for the naming of object. So this area is located at the junction of anterior occipital lobe and posterior temporal lobe. So this area for the naming of object is located at the junction of anterior occipital lobe and posterior temporal lobe. It is concerned with naming of the object. Naming of the object. Keep in mind, naming of the object originate mainly through the auditory input. Naming of the object originates mainly through the auditory input. While the details of the objects originate mainly through the visual input. So details of the object originate mainly through the visual input. So this is the area of the naming of the object. Next area is angular gyrus. Angular gyrus. Broadman's area 39. So area 39 is the angular gyrus, located between Wernicke's area and secondary visual area. So between Wernicke's area and secondary visual area is the angular gyrus, Broadman's area 39. Angular gyrus is concerned with the interpretation of visual information. Concerned with the interpretation of the visual information. So these are the speech areas involved in the control of speech mechanism: the motor speech area, Broca's area, sensory speech area, Wernicke's area, area for naming of the object, and then the angular gyrus concerned with the interpretation of the visual information. Now, in addition to these speech areas, the motor cortex, basal ganglia, cerebellum, sensory cortex, of course the speech center, speech areas, these are involved in the control of the speech, right? So the motor cortex, sensory cortex, cerebellum, basal ganglia, so all these are involved in the control of the speech mechanism. Now I tell you the pathway. When you speak a heard word or when you speak out a written word. Now first about speaking a heard word. Speaking a heard word. So you are asked some question. You hear the words and then you speak out the answer. You speak out the answer. So speaking a heard word. Heard words are received where? In the primary auditory area. So in the primary auditory area, heard words are received. And then signals go to the vernix area. Signals go to the vernix area. In the vernix area, what to be spoken, what to be expressed is decided. In the vernix area, concerned with high intellectual function, what to be spoken is decided, and then signals from vernix area go along arcuate fasciculus to the Broca's area. So from vernix area, signals go along the arcuate fasciculus to the Broca's area. From the Broca's area, then signals go to motor cortex to initiate contraction of muscles of phonation and articulation. From Broca's area, signals go to the motor cortex to initiate the contraction of muscles of phonation and articulation. So this is the pathway for speaking a heard word. What is the pathway for speaking a written word? You read a book and then you speak what do you see, right? So you loudly speak written words. You read some question and then speak out. So the pathway is that written words are received in the primary visual cortex. So written words are received in the primary visual cortex, area 17. Then signals go to the secondary visual area, area 18, 19. Then into the angular gyrus, area 39. And then into the vernix area. This is the angular gyrus, then into the vernix area. The area concerned with high intellectual function. In the vernix area, the words to be spoken, what to be spoken is decided. Words are selected. Words are arranged into sentences. Words are arranged into sentences. And then signals from vernix area go to the Broca's area. From Broca's area, signals go to the motor cortex to initiate contraction of the muscles of phonation and articulation. So this is the pathway for speaking a written word. Pathway for speaking a written word. Next we will discuss about disorders of speech. Disorders of speech. So first type of speech disorders are aphasia. 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 Aphasia are speech disorders not due to defect of hearing or vision or motor paralysis. So aphasia are disorders of speech not due to defect of hearing, vision or motor paralysis. Aphasia are due to lesion in the speech areas in the dominant hemisphere. So lesion in the speech areas in the dominant hemisphere gives rise to aphasia. So aphasia is due to lesion in the speech area in the dominant hemisphere. It is not due to defect of hearing, vision or motor paralysis. There are different types of aphasia. Different types of aphasia. The first type of aphasia is motor or non-fluent motor or non-fluent aphasia. Motor or non-fluent aphasia. In this type, the speech is non-fluent. Slow speech. So speech is non-fluent and slow. Patient feels difficulty in uttering words. Patient feels difficulty in uttering words. Speech is non-fluent, slow speech, and patient feels difficulty in uttering words. Speech is limited to a few words. Speech is limited to a few words. So sometimes words retained are those which were being spoken at the time of the accident or vascular disorder which resulted into aphasia. So in some cases, the words spoken or retained are those which were being spoken at the time of the accident or vascular disorder which resulted into aphasia. It is due to lesion in the Broca's area, the motor speech area. So lesion in the Broca's area, or motor speech area, results into motor aphasia or non-fluent aphasia. The next type of aphasia is sensory aphasia. Sensory aphasia or fluent aphasia. Sensory or fluent aphasia. In this aphasia, speech appears to be normal. Speech appears to be normal. Fluent speech. Speech is fluent. It appears to be normal. Rather, the patient speaks excessively. The patient speaks excessively. But speech carries little sense. Speech carries little sense. So patient speaks excessively. Speech appears to be normal, to be fluent speech, but it carries no sense. It carries no sense. In these cases, the lesion is in the vernix area concerned with higher intellectual function, right? So lesion is in the vernix area concerned with the higher intellectual function. So difficulty in thought formation, difficulty in selection of words to express the thoughts, words are not arranged properly, words are not arranged properly, patient feels difficulty in reading, right? And maybe in writing. So this is the sensory aphasia or fluent aphasia due to lesion in the vernix area. Our next aphasia is dyslexia. Dyslexia of word blindness. Word blindness or dyslexia. Word blindness or dyslexia. In this aphasia, patient is able to see. Patient is able to see, but cannot understand what is being seen. Can't understand what is being seen. So it can't understand what is being seen. Of course, reading or writing is disturbed. Reading or writing disturbed. This is dyslexia of word blindness. Patient can see but can't understand what is being seen. The lesion is in the angular gyrus. So in the angular gyrus, there is damage or lesion in this aphasia. Our next type of aphasia is global aphasia. Global aphasia. Global aphasia. This is a severe type of aphasia. Severe type of aphasia. The patient is totally demented. So severe type of aphasia, patient is totally demented. Totally demented. The lesion is in the vernix area. The lesion is in the vernix area. Angular gyrus, part of temporal lobe, and also the superior wall of Sylvian fissure. Superior wall of Sylvian fissure. So widespread lesion, including the vernix area, angular gyrus, part of temporal lobe, and then the superior wall of the Sylvian fissure. The patient is totally demented in global aphasia. So this was about the types of aphasia, an important speech disorder. Next disorder of speech is dysarthria. Dysarthria. Dysarthria is disordered articulation. So in this speech disorder, there is disordered articulation. Formation of words is defective. So disordered articulation of word formation becomes defective. What are the causes of dysarthria? Non-nervous causes. Non-nervous causes including cleft palate, hair lip. In cleft palate, the two halves of the palate are not fused. Two halves of the palate are not fused in cleft palate. Hair lip. The two lips are not fused together, right? I mean, the two half of the lip is not close together. Hair lip. Then loosely fitting dentures. The people who use artificial teeth, when they fit these are loose. So loosely fitted dentures, these can give rise to dysarthria, disorder of speech. Then the nervous causes of dysarthria, these include poliomyelitis, polyneuritis, myasthenia gravis, motor neuron disease, and cerebellar disease. So these are nervous causes of dysarthria. Poliomyelitis, polyneuritis, myasthenia gravis, motor neuron disease, and cerebellar disease. So this was about dysarthria, a speech disorder. Our next speech disorder is hoarseness of voice. Hoarseness of voice. Voice become hoarse. आवाज बैठ जाती है. So hoarseness of voice. It is due to different causes. So what are the causes of hoarseness of voice? Chronic laryngitis. Papilloma of the vocal cords. A benign tumor of the vocal cord is papilloma of the vocal cords. Hypothyroidism. Hysteria. In hysteria, a psychic disorder, especially in young girls, they present with some disease which is not actually there because of the psychological stress. So hysteria, chronic laryngitis, hypothyroidism, papilloma of the vocal cords, hysteria, right? Damage to recurrent laryngeal nerve. So these are the causes of hoarseness of voice or dysphonia. Dysphonia or hoarseness of voice. Causes repeat chronic laryngitis, papilloma of the vocal cords, hysteria, hypothyroidism, damage to the recurrent laryngeal nerves. Our next speech disorder is this stammering. Stammering or stuttering. What is stammering? Stammering is dysfluency of speech. Dysfluency of speech in which normal rhythm of speech is interrupted by arrest, repetition, and prolongation of words, syllables, and phrases. So in this disorder, the normal rhythm of speech is interrupted by arrest, repetition, and prolongation of words, phrases, or syllables. Right? This is the stammering or stuttering. So it is the dissonancy of speech in which normal rhythm of speech is interrupted by arrest, repetition, and prolongation of words, syllables, and phrases. Some adults stammer when there is emotional upset. So some adults stammer when there is emotional upset. Young children, especially male children, some of these they stammer. Stammering is aggravated by rapid speech, emotional states, say anxiety, rage, answering questions, and then talking to the superiors, talking to elders, talking to teachers, so talking to superiors. So these factors aggravate stammering. I told you rapid speech. When the boy speaks rapidly, they stammer. If you advise him to speak slowly, then stammering will decrease. So rapid speech. Answering question. You ask some question to the boy starts stammering. Then talking to superiors, talking to the teachers, talking to the parents. The boy or the child may stammer while talking to the teachers or superiors or the elders, parents. And then of course the emotional upsets, anxiety, other emotional upsets, it results into stammering. Which factors are involved in this stammering? First, there is familial predisposition. For stammering, there is familial predisposition. It runs in families. So stammering, it runs in families. And the familial incidence is 35 to 65%. So 35 to 65% is the familial incidence of stammering. If parents have stammering, then in the children, the chances are that 35 to 65% of the children, they may get this disorder of speech, stammering. So familial predisposition, one factor. Other factor is incomplete cerebral dominance. Incomplete cerebral dominance. And the other factor is environmental factors. Environmental factors in families which have a very strict atmosphere in the home. Very strict parents. Children are not allowed to do as per their choice, as per their will. So this results into this strict atmosphere in the home. It may be a factor which can lead to stammering in the children. Why does stammering occur? Normally there is coordination. Normally there is coordination between laryngeal reflexes and the voluntary act of speaking. Right? So normally there is coordination between laryngeal reflexes and voluntary act of speaking. You want to speak, when you start speaking, there will be coordination between the voluntary act of speech and the laryngeal reflexes, and the vocal cords are adducted, other reflexes. Defect in this coordination, it results into stammering. So defect in this coordination, it results into stammering. Which coordination? Coordination between the voluntary act of speech and the laryngeal reflexes. Stammering, of course, is more common in boys. In boys, stammering is more common. Now, in those who stammer, when they sing or when they recite from Holy Quran, there is no stammering. So stammering is not affected. It does not affect the singing or the recitation of the Holy Quran. Right? So this was about the speech disorders, including the stammering or stuttering. Thank you.